3.
So good morning, everybody. Just waiting a few seconds so that everyone can join us from the waiting room. So we will start in just a few seconds. Still steadily flooding in, so just bear with us for a little bit longer and then we will get underway. Okay, I suggest that we start. Good morning and a very warm welcome on behalf of FPA to this online event on Towards a New Normal, Why Boosting Cardiovascular Health is Critical. My name is Jackie Davis. I'll have the privilege of moderating our discussion this morning as we consider the impact the COVID pandemic has had on patients with cardiovascular disease and those at risk of development. We're going to consider the lessons learned during the pandemic and how to apply them, and explore opportunities to build back better, strengthen healthcare systems, and make them more resilient and equitable. And for this, we're going to use a report commissioned by the FPA CVD network in collaboration with PwC to understand more about the impact of COVID on the 60 million CVD patients in Europe as the basis for our discussion. A little bit of housekeeping before I introduce our host today. If you have a question, please write it in the Q&A box, not the chat. Keep that for any technical issues you might have. Please put it in the Q&A box and please be as brief as possible. And if you want to tweet about what we're discussing today, and we do urge you to get that message out about the importance of this issue, please use the hashtag #PowerUpHealth. It is now my great pleasure to give the floor to our host for today's event, Paul Rübig. He's a former MEP and he's now a member of the European Economic and Social Committee, and he's on the governing board of the European Institute of Innovation and Technology, EIT. He's been a great champion of cardiovascular disease, and indeed co-authored a report by the committee a little earlier this year calling for a CVD mission similar to the Beating Cancer Plan that's been launched. Paul, we are very grateful to have you with us today. Thank you so much for hosting this event, and over to you to kick us off.
Yes, a very warm welcome to our meeting. I think it's very good to see that the world is moving on, and that we have to look into the future. What can we do to improve our daily living? And of course, as you mentioned, I'm now a member of the European Economic and Social Committee, and the European Economic and Social Committee is advising a lot of institutions on European level, not only the European Parliament, the councils, the commissions, the agencies, but our main agenda is to reach out into the member states, into our organizations, and we are the so-called organized civil society, and we try to bring new ideas, options assessment. We try to give a very good impact assessment to what's coming up from the European Commission, from the Council, and we are writing reports on this. And in these reports, of course, a lot of experts listen to. We look how we can structure the different issues. And this year I did 4 reports up till now. The one and most important maybe is a new European research area. European research area for innovation as well. It's approximately 450 billion euro, which we every year spend for research and innovation. European Union has a budget of 7 years of approximately 100 billion. So it's a very small part which we do on European level, but the real level is in our member states. And so the question, and that was the second report which I did, is packed on research and innovation in Europe. So how can we bring the patients, the citizens, how can we bring them together because it's clear that within our committee, I was rapporteur in the INT committee, which means we are responsible for the internal market, so for the consumers, for the patients, and for the production. And production is key in developing new strategies. And now I'm coming to the report where we are talking today. It's European missions. In the European missions, one mission is to eliminate cancer. And we all know that also COVID had heavy impact on our daily life. But the truth is that cardiovascular diseases are the main part of burden which we have to take. And my co-rapporteur, Mrs. Bogusz, had really heavy impact on this report to see how can we get a new way of looking into maybe a new CVD mission or how to integrate the CVD into this agenda. Therefore, I think it's good to see that also within the European Institute of Technology, the EIT Health, we are working together between industry, business, SMEs, research, science, and education. And I think that's key that we have this debate. And today I'm very happy to announce that we have the CVD in our focus and what can we do on European level. Thank you.
Thank you very much indeed, Paul. And I'd like to come back to that question of whether there should be a mission. If there should, what should the key elements of that mission be? But before I introduce our panel to discuss this issue on an entirely interactive basis, I'm delighted to welcome Ömer Saka, who is Partner for Life Sciences and Healthcare at PwC. And Ömer is going to present the study that I mentioned earlier, which, as I say, will form the basis for the debate that follows. And Paul will be back with us later on for the panel. And Ömer's not joining the panel, but if you did have any questions for him and you want to ask them, please do put them in the Q&A box and I will bring him back as and when necessary later on. But Ömer, over to you to present the study.
Jackie, thank you very much. If you could have the slides projected, thank you. It's obviously a great privilege for me to present our findings on behalf of myself, my team at PwC, but also my colleagues at FPIA. We spent about 9 months working on this report, and hopefully the findings will initiate a debate. Now, we call our report Return to New Normal for a few reasons. COVID crisis has pointed us towards a number of important facts. Now, number one, we realized that we have the scientific foresight and the technical capability to respond to forecast emerging health crises. For example, we knew that the SARS virus was very risky pathogen, and we could have taken global action against it, and we didn't, which led to the loss of many lives and ruined the lives of the ones who stayed alive, both mentally but also metabolically. We realized that the talk of sustainability and resilience could only be put into action if we actually evaluate the options that are before us and develop plans to execute on these aims. Strategy is important, but implementation, operation are the key towards success. We also realized that getting prepared for a healthcare fallout should not be jeopardizing the care for the rest of the population. It has been a known fact that the demand for healthcare is going to expand. Nobel laureates such as William Baumol has long argued that investment into healthcare should and will take up a larger chunk of the economy. This is inevitable, and we should start acting towards that ideal. The improvement of healthcare of individuals beyond its impact on productivity and utility generates but it's the human right. It's also essential to attend to the basic socioeconomic indicators as we do so, such as inequity between different population groups. Therefore, this crisis, in our perspective, has initiated the thinking and the acting towards meeting the requirements of this new normal. CVD, we thought, is probably the most prominent place to start from because it does generate the largest burden to the societies around the world, which is avoidable for a significant proportion of those who suffer from it. Therefore, with the new normal, not only the need to immediately evaluate the impact of health crisis on healthcare systems will be necessary, but also to initiate the thinking and action towards requirements of that new normal. Just very briefly, similar to the predecessor of this report, when together with FPR colleagues, we investigated the impact of COVID more broadly on healthcare systems. Here, the idea was to investigate the emerging data on the impact of COVID and CVD specifically. As we evaluated this interaction, we also aimed to point a finger towards a certain tactical direction. This is to streamline the efforts towards the most effective interventions as they are seen and reflected on by the top experts in this field. If you have the chance to read the report, you will find a large references section that we've also undertaken to evaluate the available literature around this topic. So if you move to the next slide, thank you. Let's start with the facts. I don't think I have to remind the audience here on the massive burden that CVD causes. 31% of all global deaths and slightly a more modest number in Europe can be attributable to CVDs. Further, COVID had an impact on the state of CVD by elevating the risk for almost all of the CVD manifestations, heart failures, atrial fibrillation, myocarditis, from the 30 days of onset to 1 year after the acute infection are still seen to be more severe consequences of patients who suffered from COVID. Another important factor needs to be mentioned here, and we attempted to underline this in several points in our report. The convergence of forces under the impact of an acute stresses such as COVID-19, acting on top of the underlying chronic diseases determines a syndemic situation. Syndemic is the aggregation of diseases on a background of social and economic disparity with the result of exacerbating the adverse effects of each separate disease. Therefore, in the new normal, we do not only need to think on how to mitigate the acute stresses' detrimental impact on the population, but rather than haphazardly responding to acute crisis, we would need to understand the consequences of such vast-ranging health issues and respond to them appropriately to maintain population health at levels already attained. It's our opinion that this could also only be achieved by understanding where we have actually had shortcomings already, and by addressing these issues, we can get to the new normal. The opinions, of course, as they have been formulated, were very varied. In the next slide, I just want to underline some of the factors that emerged immediately in our interviews, particularly the two factors. Number one, missed identification of CVDs or CVDs related to risk factors were mentioned almost unanimously by all of the experts as a major shortcoming of the healthcare systems during the COVID crisis. Of course, in relation to that, the delayed presentation to the system and the delays in seeking care by patients was a natural follow-on shortcoming of the healthcare systems as well. We have collected several anecdotes from the experts that we had the chance to speak with. Some of these anecdotes were actually attributed to direct patient impact that they have experienced, but which the space of that we had in the report did not allow us to report them all. But we should also underline the factors which were already present in the healthcare systems in dealing with COVID as important elements, such as uneven access to the healthcare services and vulnerable populations carrying the majority of the burden were already aspects of the healthcare. They were exacerbated by the COVID crisis. The investigation of access mortality as a result of a combination of COVID and CVD is still under investigation, but we've outlined in our report clearly that the initial indications demonstrate that there was significant access mortality as a result. If you could move on to the next slide, I would like to now underline how in defining the current picture, we actually wanted to bring forward the suggestions that could counteract and perhaps counterbalance this grim picture that we faced in our investigation. We came up with 3 main suggestions and recommendations to attend to the shortcomings observed. Number 1, improving the initial recognition of symptoms and disease. Number 2, ensuring treatment initiation, maintenance, and follow-up, especially by utilizing new technologies available to us. And of course, finally, in order to be able to achieve these former objectives, ensure that we collect data effectively across the continent in Europe, ensuring that the regions, populations, and countries are covered sufficiently, not only to be able to understand the emergence of issues, but also to be able to determine the early, but the long-term, midterm, and long-term actions. Let me start by detailing out from the first area. We have evidence-based medicine on our side to have a good understanding on the established risk factors for CVD, such as smoking, diabetes, obesity, high blood pressure, and hyperlipidemia. And we have tests and methods and technologies to investigate those factors. Now, effective management of these factors by monitoring even the vital signs, such as blood pressure, continuously, will already improve the management of CVDs. In fact, longevity research suggests that the individuals who monitor their weight on their own daily already experience decreased amount of cardiovascular events throughout their life. But there are also more sophisticated metrics that are available to us. There are more sophisticated biomarkers at our disposal, especially now that we understand the impact of inflammatory processes on cardiovascular diseases, such as high sensitivity C-reactive protein, homocysteines, oxidative stress, and so on and so forth. These factors should also be considered for short-term, mid-term, and long-term management of CVDs. To do that, we have to be able to establish the right pathways, the right patterns that fit the right populations, and obviously there is a certain individual investigation that needs to be taken forward in the countries based on the population background, based on incidence and prevalence. Now, in the next slide, I'd like to underline, now that we've recognized the disorders, how do we attend to them? For example, in Western Europe, it's estimated that 71% of the individuals with hypertension are diagnosed, but only 61% of these patients receive treatment, and only 40% of these patients actually achieve appropriate control of their condition. In Central and Eastern Europe, these figures are even more severe. Only 52% of the patients are treated, but only just about 20% reach control levels. Essentially, in the report, we're calling for the setting up of healthcare systems that observe the management of CVDs in its continuity, and rewarding practitioners and healthcare professionals who help ensure that continuity. We are giving examples in our report of systems which reward appropriate management of CVDs, not necessarily only rewarding testing and prescription, but also the appropriate use of monitoring in the long term and in the follow-up of patients. We make a specific point in the report on the use of digital technologies. No space would have been sufficient to expand on that issue sufficiently, but we are actually carrying out another study at the moment to understand the specific use of technology reported outcomes in the case of cardiovascular diseases. In the next slide, I would like to draw your attention finally that we do need to base our solutions on facts. Development of precision public health will only be possible with the emergence of wide-ranging data collection and the accessing of this data by the specialists who have the means to interpret it. The establishment of EU surveillance systems initiated by European Centre for Disease Control or the Berlin Hub set up by WHO are great initiatives to understand the emergence of disorders. In the new path forward towards the new normal, we also need to understand the impact of initial responses to healthcare challenges. And of course, this can only be done with the use of data to determine the long-term consequences of cardiovascular diseases, not only clinically, but on the socioeconomic indicators, which are often overlooked, such as equity, welfare of the populations, and the unmet need of all the aforementioned factors between population groups in Europe. I think I have not exceeded my time, but finally allow me to underline that we hope that our recommendations complement the priorities listed in the action plan for the prevention and control of non-communicable diseases in the WHO European region. We as a group hope that the members of the audience, members of the panel, and members of the wider interested group, the stakeholders, would come forward with suggestions to make changes in the attributes and the future perspectives of managing cardiovascular diseases that we address in this report. We are looking forward to building these partnerships, building these collaborations across the board and across the European community. And hopefully we could create the platform to act on the identified issues here together with your help. I'm looking forward to the discussion by the distinguished guests in the panel. And Jackie, hopefully I haven't overstepped my time. Thank you.
Not at all, Ömer. Thank you very much for that. Very clear, those recommendations, which we will discuss with our panel. And as I say, Ömer will remain available. If you do have any questions, please do put them in the Q&A box. Delighted to welcome back Paul Rübig, and also joining Paul and I to discuss all of this, to give us a policy perspective. Alongside Paul, we have Stefan Schreck, advisor for stakeholder relations in the European Commission's Directorate General for Health and Food Safety, DG SANTE. To give us a patient perspective, we have Neil Johnson, founder and director of the Global Heart Hub, and Birgit, CEO of the European Heart Network. A very warm welcome to you. And to give us an example of what can be done, the sorts of things that are being done and can be done to address these issues, lovely to have with us Peter Vasko, chairman of SWEDEHEART. We'll tell you a little bit more about that as we go along. But a very warm welcome to you all. And just really by way of setting the context, and Stefan, perhaps I could come to you. I mean, the Healthier Together initiative, under which the plan is being developed for non-communicable diseases, does talk about this as very much an element of building back better. Why do you believe, we heard, and if you see in the study, it talks about those accumulated stresses on health care services, as well as the impact of COVID, the short-term shocks. Why do you believe it's so important to address this issue now?
I think that was pointed out by Ömer quite convincingly, because we have seen COVID-19 has demonstrated that the burden of non-communicable diseases is not just a problem in itself, it also makes it much more difficult to react to a pandemic, and actually increases severity of a pandemic quite enormously. I mean, and I don't need to repeat the specific points Ömer made there. So in fact, when we talk about the lessons learned from the pandemic, and you will certainly know about the Health Union proposals the Commission also made, we have to be aware that this cannot just be reacting to the agent, to the virus, and prepare for inhibiting its spread and dealing with the consequences, but we also have to prepare society and citizens better, making them just more resilient in health terms. And I think that quite easily demonstrates why it is important to have such an initiative now.
Thank you very much. And we'll come back on what that initiative might look like and the key elements of a strategy for moving forward. Be interested to get your reaction to those recommendations that Ömer has outlined. But Neil, from a patient perspective, I mean, do you feel, I think what we're hearing is that COVID underlined those and exposed some of the problems that we face in tackling this issue, but it was a problem that already existed. Do you believe the right level of attention is now being paid to it? Paul was talking earlier about having a CVD mission alongside the cancer mission. Do we really need now a much greater push to put this front and center?
Absolutely. As the report suggested, basically COVID gave oxygen to the fire of cardiovascular disease. It exposed the vulnerability of all of those who were living with undetected or indeed underlying cardiovascular conditions. I think the COVID crisis really exposed our healthcare systems. They were not pandemic ready. There were some elements of public health messaging which was actually damaging for cardiovascular patients. I think very many patients across some countries felt abandoned, actually, particularly the elderly and frail. And this is very much down to the systems and the processes by which the patient journey during COVID was not really considered. And so for that and all the other reasons that have been outlined, yes, this is a very urgent issue, and it does require a concerted action, and that will require action at each national level and also collectively at a European level.
I want to come back on what that would look like. What are the real challenges as you see them in a moment? But Birgit, COVID, I like that expression Neil used, gave oxygen to the fire of COVID. How do you see the situation? How did you see the situation pre-COVID? And for you now, as we begin to emerge from the pandemic, the urgency to act on some of these lessons that we've been learning?
Absolutely, Jackie. So coming in for each, the Alliance for Cardiovascular Health, bringing a lot of partners together among FBR and Global Heart Hub. So I'm delighted to give a bit the perspective here to say that it was already bad before COVID, the situation, high mortality, killer #1 in Europe worldwide, more than 60 million people living in the EU with CVD. So that's drastic. And then COVID coming in and being a double sword. On the one hand side, slaying those with CVD already and other people surviving COVID, coming out with a CVD outcome. So it could not get worse. So it is, I think it is, it woke us all up primarily for the issue of health, of creating a healthy population, but bringing CVD so much in the forefront and dragging a bit back out of the corner because you said, well, it's an easy debt, it's a lifestyle. So it is not. It's a fundamental health issue in Europe, and patients are suffering from it. And I think that is the issue we need to address to see that we have access to healthcare and delivery to healthcare for CVD patients where we can.
And you point to one of the challenges there when you talked about the perception of CVD and it being a lifestyle problem. And I wonder the degree to which you think, as part of the conversation we're having now, we need to do more to address that issue and underline that it isn't simply a case of lifestyle choices. But Peter, complete the picture for us in terms of this is an issue, and you maybe say 2 words already about SWEDEHEART and the registry. We'll come back in more detail to it later, but how long it's been running and why you believe now is the time when we really need to step up action in this area.
First, I must say a thank you to the pharmaceutical industry, because we take for sure now that we have the vaccine and we calm down about the panic. But I would say at first, thank you for the vaccines. That was the biggest game changer in healthcare in my life in some way. Second, someone uses very big words about this pandemic. I think it was a very big stress test, but for a functional healthcare system, we still coped with it. We have problems with the acute care, and the intensive care units and the special COVID care units struggled, but the rest of them, they didn't work so much on the pandemic. The orthopedics didn't do so much, but the biggest problem for us now is the backlog, the work we didn't do under the pandemic. But I would say that the most important thing in our systems are the trust and confidence for government and health authorities. And in those days, with the things that happen on Facebook and internet, it's very, very important that we authorities are staying stable and can keep the trust and confidence from the public. So I think that's the most important thing, not to think too big or too small, but to keep the confidence in the public. Then we can change the way we are working in the future.
Absolutely. So when it comes to what are the challenges that we face now, what are the most important issues, Paul? That backlog, of course, one of them, and therefore also the prevention. So we're not adding to the caseload, this focus on population screening, on, and not population-wide, but also that targeted screening that Ömer was talking about. What do you see as the most important challenges, Paul, now to learn these lessons from COVID, to respond to this urgency, which all our speakers have indicated was already there, but has now been underlined? What's the most important challenges from your perspective? Paul, you're muted. Could you?
Yes.
There we are.
Thank you. For me personally, of course, it's the data. We would need a data warehouse where we collect all the information about what's in reality going on. Some years ago, I was in China, in Beijing, in the Ministry of Science and Research, and we had a long debate with the Artificial Intelligence Department. And, you know, one of the guys asked me, Mr. Rübig, do you know what is the reason why so many patients are dying in your hospitals? Huh? And I said, yes, maybe it's virus, bacteria, disease, whatever. He said, no. Then I said, please tell me, what is the reason why so many patients have to die? He said, it's data protection. You really don't know what's going on in your hospital. You don't collect the data in the right way. You don't have the standards for collecting it. And you will see that all the pharma production will go to China, because in China, all data belongs to the state. And we know if in the north of China, some makes problems, and in the south, he knows how to solve the problems. Machine learning will bring them together, and overall the situation for the patients, it's much better. But I have also a practical example. You know, as COVID started, we have seen that we can collect data from sewage treatment plants. And, you know, 4 days before it appears in the people, you can measure it in sewage treatment plants. And you can, if you take all sewage treatment plants in the world, you can see how the virus moves on sewage treatment plant to the other. You can detect also the mutation of this virus. And then, of course, you can see which vaccination did we have around these different sewage treatment plants. And then you can see which vaccination worked with which mutation. And then you can go and look to the data, how many people were going into the hospitals, how were they treated in the hospital, which pharmacies would work, which won't work, and at least who has to die because we didn't find the right answer. So you see, data is key, and that's also in CVD. We should look exactly from where it comes. I myself had a problem with CVD because after the third vaccination, I was 2 days in the hospital, and they checked all my data, and they found out, yes, it's more or less normal. And I was very shocked on this diagnosis, that it's normal that after your third vaccination, maybe you can have some heart disease. So you see, data and transparency of data and accuracy of data and standards of data are key for me.
Come back to that. I want to continue to build the catalogue of challenges, but then particularly come back to Peter on that question of data and the cardiac registry that you've created. There's also, of course, a European initiative in this area. I'll come back on that. But in terms of building that picture of the challenges, Birgit, for you, of all the issues that the study looked at, what for you are the most important challenges?
I think the biggest challenge is to find people, to have the early detection and to avoid. I mean, it's always the same message. The prevention is better than cure. So if you catch people early, then you can intervene much more targeted and much more sufficiently than trying to remedy the damage which has been provoked. And I think what we also need to keep in mind, we are in Europe, and there are disparities across Europe between West and the East. So we have to catch the social disadvantaged people, which has been mentioned in the PwC report quite extensively. EHN, European Heart Network, had a project with the Irish farmers, a male population, very remote, very reluctant to undergo screening programs. And it's important to catch really everyone and not leave anyone else. So each also
as the screening and that
screening.
Just a quick follow-up, if I might. Anna Day from our audience on this point about groups that you need to reach suggests that actually She says cardiovascular disease is the leading cause of death in women in Europe and worldwide. And yet cardiovascular disease in women remains understudied, under-recognized, underdiagnosed and undertreated. How can we reduce the global burden of cardiovascular disease in women? Because I know you were saying rural areas, men who won't get screened. Also a problem among women?
Of
Would
course,
you agree
also,
with the comment?
Yeah, I do agree. I think we have, in science, we have a bit of a bias that we look at the male, white, middle-aged man, but that we do not see so much children in studies and clinical trials, and we do not see so much women, which are half of the population. So we have a problem there already in science, and I think this translates also in the practice.
Come back maybe on that point in the study where it says, you know, we need population-wide screening, but also then this concentrated interventions, as it puts it, in key areas. But Neil, continue, if you would, to help build the picture of the challenges we need to address. Would you agree with what you've already heard? Would you add something to that list?
Yes, absolutely. As Birgit has said, early detection, screening is so important. And as the report identified, it's not just screening, then it's timely intervention the whole way through. But I think there's also two other fundamental pieces to this discussion. One is, I think we need to, at the individual level, we need to reframe cardiovascular health. We need to look at the promotion of cardiovascular health as an investment in our future. This is something that we really need to consider in the context of the changing demographics. We're going to live longer, so we need to prepare for living healthier and living longer. And secondly, I think in the context of reframing the discussion on cardiovascular disease, we need to, you know, get to a point where society understands that this is a real burning issue, that, you know, people always think of cancer, but ischemic heart disease, ASCVD, is the cancer in the cardiovascular world, a slow burning, insidious condition, which we have the answers to. We can detect it and we can treat it, but we are not systematically managing it.
And an interesting point, and Paul, I'd like to get a reaction from you in a moment that will complete the picture first. But, you know, I mentioned earlier the cancer mission, you mentioned it too, the Beating Cancer Plan, a lot of focus on cancer. And I think you're saying this is another area where we need to have an equal focus to address that issue that Neil has raised. But I'll come to you in a moment. Let me just complete the picture in terms of the challenges. Peter, for you, the data warehouse, the collection of data and making it available for use in the ways Paul was talking about, obviously key. The central challenge for you, or what else would you highlight?
The central challenge for me is harmonization of data, so that we, if you speak about apples, we don't mean peas. So, harmonization and standardization, and even in an extremely small country as Sweden, we have a lot of data sets when we collect patient information. So harmonization and of data collection, and we are now, as you mentioned, and as it's mentioned in the report, trying to make an effort for European harmonization about our heart variables. And starting from Sweden, we are now reaching out in Estonia, Hungary, Portugal, and then Sweden, Denmark, Iceland, Romania, Lithuania, and a bit oddly, Singapore, for harmonization of variables in acute coronary syndromes. So harmonization and standardization is, I think, the first important thing when you are collecting data.
Thank you very much. I'd like to come back on your experience and what we've learned from the data that you collect in a moment. But Stefan, complete the picture for us. Was there anything else we should be focusing on in this conversation?
Yeah, maybe. I mean, maybe I can say a word on the data question and the harmonization of data and collection of data. It's obvious that data are really super important. There's absolutely no question about this. And there are two challenges. There's first the GDPR. Yeah, that actually makes it very difficult to exchange data among member states, for example, to have comparable data at European level, insofar as they are not anonymous data. Yes, and then the other thing is collecting data is in principle a good idea, but it's also very expensive in particular, if you want to have harmonized data. I mean, we have obviously ongoing conversations with member states in what areas we need better and better. Harmonized is maybe not the right word. We need the same case definitions. We need indeed to compare apples with apples. This is always a very challenging discussion with member states. We can see it now, for example, obviously we need to have better data on communicable diseases as a direct consequence of COVID-19. And already that is not so easy as a discussion, let alone for non-communicable diseases. So that I think that not everybody is aware how complicated this is, and we need to be aware of that. And secondly, what the main challenge is, if you look at this from the perspective of the Commission, to put it like that, we have 27 member states. And what we have seen in the past, that if we just write documents which tell member states what they should be doing, what is the right way to set up a health system, and that is good and necessary, because there needs to be some consensus on what the best way of doing things would be. But in fact, the real challenge is to motivate member states to make changes in the system, because that means that people who since decades did things in a certain way need to do it in a different way. And that is quite complicated for all systems, including the health systems. And therefore, we need to find innovative ways to not just make the case why something needs to be done, but to create conditions in which the necessary change can be triggered in member states. And that's what we are trying to do with our Healthier Together initiative. We don't really have, our biggest problem is not that we don't know what should be done. Our biggest problem is to apply the knowledge we have already. And we try to do this in a process that motivates member states better than before, by using a bottom-up process, by asking the member states, by not trying to define at European level in the traditional way what is best, but by asking member states where they want to improve, and then by trying to identify approaches which have been tested already, which are not, let's say, theoretical considerations, but which have been implemented already somewhere with success. And then we try to find other member states with the same problem who would like to import those solutions and help them importing it. So and the challenge is to really create a process that motivates member states sufficiently to actually do it.
So it'd be very interesting. I'd love to get your thoughts on an issue that is addressed in the report about the incentivization of CDV programs. What was CVD? What works? Is it financial incentives? Is it benchmarking? What is it? But there's a comment really from Christine Den, and then I want to come back to Paul Rübig on this centrality of the issue and the comparison that was made with cancer. Christine Den says, what worries me as a patient representative of the CVD community is we see long COVID impacts on the heart. There's been increasing heart failure, but on the other hand, we are not prepared to cope with these added patients. Many countries still don't have CVD plans, cancer is given priority, and patients have to fight for acceptance and rehabilitation. I'm just going to cut to the chase. She says, I am worried that we will be running behind a departing train and lose too many patients' lives. And I really hope that the Healthier Together initiative will be a game changer for the CVD community. Paul, that game changer, how important do you think it is as a symbol of how important this issue is, and to really get that momentum and make sure that train is not departing, that we have a mission, a plan like the Beating Cancer Plan in order to really put this issue front and center?
Yes, first of all, it's a global issue. I think we should look what we can do in the global institutions to get a trigger on fighting for this area. I'm very specialized on Horizon Europe. In Parliament, I was also responsible for the budget. And so the 3 pillars of Horizon Europe shows us very clearly how we have to act. It's pillar 1, it's excellence in science. European Research Council, they go very much into the details, which are at least a good trigger for the pillar 2, for the global challenges of European industrial competitiveness, especially in the health area. And pillar 3 is, of course, European innovation ecosystems, where we can see that health is underestimated. So looking to the European research area, I think the main issue is that the Horizon Europe program has to have a deeper link into the national systems. And that's where the Commission and the Council is now working on. I was not long ago in a Council working group where we had a big debate on it. I'm also observer for the European Economic and Social Committee at the European Commission, at the ERA network. So how to get the right infrastructure, I think that's quite important for all of us. And so this new challenge needs a real good impact assessment.
Thank you very much indeed. Let's drill into some of the detail of the study and some of the issues it looks at. One of the things it talks about, and you've already referred to it because you've talked about vulnerable groups and the specific actions that are needed. But Stefan, I'm just wondering, do we need to do more in this area as in others to tackle health inequalities across Europe and make sure and promote equal access to new treatments, innovations in particular? And how do you see the eventual plan that emerges from this helping to address that issue?
Yeah, that's obviously a key issue, basically across the whole health sector. And actually, we are always at risk of making things worse by introducing new measures, because many new measures then are taken up actually only by the part of the population that is already privileged. And by this making the inequalities even bigger, and we are totally aware of that in everything what we do now. So looking at that aspect is key in the implementation of the Healthier Together initiative. And actually, we might ultimately even learn from what we do in the Europe-Speaking Cancer Plan, where actually part of the plan is establishing an inequalities registry. So a database that does not collect just data on the disease, incidence and prevalence, and all the data related to that, but also which group of citizens has less access to any part of the whole area of what we want to address there in the area of cancer. And that's a pilot, if you so wish. This is a real challenge because there are big discussions about what actually should be measured there. And this is also expensive and complicated to do, but everybody is really very interested in this because it's the first. And if it does work, then we will certainly, in the end, also learn from this for other non-communicable diseases, including cardiovascular diseases.
Peter, is this just to understand, Peter, is this something that you look at as part of the information you collect in the SWEDEHEART registry or not?
Ask we once more, please, the question.
We were talking there, Stefan was talking about creating an inequalities registry. So you look also at this issue of which group of citizens have access, don't have access, and correlate that with the other statistics, the health data that you have. Is this something that is included in the data that you collect in the registry?
I should say that to be in a registry is good for the patient. So it's a if you are in a registry, you get better care because those people that are active in registration, they are delivering better care. So that's the first point where you have this in, how do you say it in English, inequality.
Yeah.
Yes.
Yes.
But the government says to us that we couldn't have it like that. But we have proven more times that if you have registries, then you get better care because then you are in a place where people care more about the.
Sorry, can you explain what you mean by the government said you couldn't?
It's not allowed to have unequal care in Sweden.
Indeed not.
No. And then we know that if you have more dedicated personnel, you get better care. So it's a problem in the system.
Yes. So it exacerbates the inequalities
yes.
by having the registries. Neil, from your perspective, what do you think needs to be done, can be done to address this issue, and not just sort of inequalities in basic access to care, but particularly in this area of access, faster access to innovative medicines?
Well, I think we all know for a long time that there's been, unequal access, and across Europe it has varied. But I think what the pandemic has exacerbated is general access. It has highlighted the fact that most healthcare systems actually don't seem to be capable of responding to the burden of cardiovascular disease. The whole system requires a revamp and major investment, I think.
Birgit, from your perspective, what do we need to do particularly to address this issue? Because you talked earlier about the most vulnerable groups. What do you think needs to be done?
Well, I mean, there's with my EHN hat, the European Heart Network, I'd say that we need health and digital literacy so that patients also find their way to access healthcare facilities. But to do this, I think we need in public investment. And as we have this European health data space, we have all the brilliant technology. We have all possibilities in innovation there, but we need to make sure that while we steer towards that, using the data registries Peter is mentioning, utilizing Stefan's Healthier Together initiative, we need to make sure that the innovation, the digitalization does not lead to exacerbate the existing inequality. So we need to harness digital tools, but make it accessible and improve that everybody can participate in it. So health literacy and digital literacy.
Yeah, that's very interesting, because we look at digitalization and see all the opportunities it offers, but you're saying there is this inherent risk. Stefan, did you want to come in on that point?
Yeah, that is absolutely true. I mean, this is, and we see it as, indeed, we are setting up this European health data space as a real big opportunity, but we also have the digital divide. Yeah, we have part of population which is very keen on using digital tools also for health. And then there's another part of population, and this might actually be the same part which is already disadvantaged in health terms, who do not have access. And this is really a key problem in this process, which needs to be addressed.
And just to ask, because you made that point earlier when you said we're very aware of the things we're doing that tend always to be taken up by those already in a more privileged position. How can you, just to follow up on that, Stefan, I mean, you want to use these tools. It would be crazy not to take advantage of them. But how can you address these issues? What sort of approaches are you looking at?
Well, first of all, this needs to be built into any specific project that is planned in this area. There needs to be a specific consideration how to ensure that everybody has access, of course, taking into account the situation in society. Which means if somebody doesn't have internet access, then you can do whatever you want. You will not, that person will not have access to any kind of services which are provided over the internet. So which means in that case, we have to ensure that they have internet access first, for example, as a rather simple example. And for each individual project, you have to look at how to improve access for those who are unlikely to have access. That's clearly one thing. And then it's also clear that when we are implementing this also needs to be monitored somehow. Yeah, so we have to evaluate whether it works actually.
Absolutely.
And in the end, I mean, there might also be some sort of permanent monitoring whether access is the same for all. But it's a real challenge, no doubt.
Thank you. Paul, you wanted to come in on this point. And then Peter.
Yes, because it's a very important point. You know, public health is very important. So we should do our utmost to have full access to the possibilities. And we have to see that, of course, a personalized treatment should be the focus of the system. Personalized treatment, because it's clear that the patients want to also have the freedom of choice. So to see to which doctor, to which hospital you go, and also the standards of the hospital, it's quite different. And so the free choice is also something where we should look into the detail. How can we get an individualized treatment and screening, and also giving a choice to the patients what is possible in the question of the first treatment, and if you had a problem, what could you else do? So the value chain of delivering health, I think that should be seen as a lifetime circle. How can we provide the best effects?
Thank you very much. Peter, you also wanted to come in.
I just wanted to, Stefan said it was very costly to collect data. And I have a suggestion when it doesn't cost anything at all. We made a historical mistake when we built our medical records. They were old-fashioned in day one. Of course, they should have been made in that way that we could collect data about what sort of quality you are delivering when you are working and making the medical records. And so we should collect the data at the source, at the medical record, which shouldn't have any works with persons collecting manually, looking at the medical records and collecting them in a web formula. The data should be collected immediately when you collect it in the medical records. And those,
thank you. I'll also be interested to get your thoughts in a moment on other lessons based on your experience at SWEDEHEART for people trying to emulate what you've done about what needs to be done. But Neil, you wanted to come in on this point.
Yeah, to be honest, it's a little bit surreal listening to the conversation, about data collection and access, in the sense that I think we need to come back to the reality of actually where we're at today. And there are probably people listening into this call who, as we speak, can't get to see their primary care physician. And this is right across Europe. We have major issues in terms of workforce planning. We've major issues in terms of waiting lists and backlogs. We've major issues in terms of disconnected health. Again, you can have all the data in the world, but if it's not being used in a connected way, it's absolutely useless. And in the context of data collection, we don't even have electronic records in many European countries. So there are more fundamental issues, I think, that need to be discussed in terms of the wider health response to cardiovascular disease. This is a major issue, and we need a major response. And that response is going to require investment at very fundamental levels.
Where should that investment be targeted? I'm reminded that the EU for Health programme says 20% of the budget of that programme should be used for health promotion, for disease prevention. Where is that investment most needed, Neil, from your point of view?
Well, I'd say that very many countries couldn't actually answer the question if you asked them how much of their health budget is going on cardiovascular disease prevention, because there is a serious lack of focus on prevention right across Europe. Many countries don't even have a national cardiovascular health strategy, let alone have a focus on prevention. So we need to get real about this and realize that we have a public health issue here. So it's been far greater than COVID, with greatest respect, in terms of the burden. In my country, for example, we lost 5,000 or just over 5,000 people from COVID, which is tragic. We lose 10,000 people a year from cardiovascular disease, and nothing has changed, and nothing is changing because we're lacking the political will. And this is where I think the EACH initiative is calling for a European action plan, which is critical, but fundamental, and to underpin that needs to be national plans.
Come back on that in a moment. And you talking there about the lack of focus on prevention. I'm also wondering about the issue of secondary prevention, which is mentioned in the study, because 1 in 2 heart attacks are repeat incidences. And are we doing enough in that area? But Birgit, you wanted to come back in.
Yeah, just shortly to make the bridge to say, yeah, we need definitely primary prevention as always as the first. But what we also need is to link primary, secondary prevention in a pathway, actually, which is patient-centered, and that which brings high quality and which brings the general practitioner, the specialists together, and afterwards also the rehabilitation, in order not to get lost, to lose the patient. And we also need to make this pathway user-friendly and innovative, so it's easy accessible. So I think we have to think to make a red thread throughout our healthcare system to be sure we do not lose anyone behind. And I think this is the idea of having a more of an overarching plan so that we do not miss out. Going back to secondary prevention, indeed, this is what EHN has also highlighted in its paper on early screening, that we need to find people also with factors which you can't prevent because they are congenital or inherited. So we need to touch on everybody, and also maybe the less obvious one. So, and this is also seen cardiovascular health in a more holistic way, saying, yeah, there's the prevention side, primary prevention side, a healthy life, but there's also the issue of, let's say, underlying comorbidities, congenital diseases, and there is also infection, as we've seen with COVID. So we need also to make the bridge between infectious diseases and non-communicable diseases. And there's, again, we have an agency, the ECDC in Stockholm, but it would be good if they had the mandate as well on non-communicable diseases, going back to data. So we are perfectly informed, but it is to come back, secondary prevention, early detection, and identify those people at risk so that we can catch them early enough before the stroke happens and the heart attack. That is decisive. And there, I think we can be a bit better on getting these people on the radar and don't miss out.
Peter, I don't know, before I come back to Stefan and Paul about this lack of a focus, as Neil put it, on prevention generally, and then this question of secondary. Peter, did you have a comment to this issue?
Our answer is to, as always, measure our which goals we are reaching. So after a heart attack, we have a visit after 6 to 10 weeks, and then we have a last visit after 12 months, and then we measure how good we have been to reach the goals. Hypertension 81%, the hyperlipidemia down to 1.4 is very good today. So it's measuring and not to hide the inequalities, but to make them transparent.
Stefan, from your perspective, and the aim of the Healthier Together initiative is to reduce the burden of non-communicable diseases generally, and of course prevention absolutely central. But Neil saying we're not focusing enough on it. Would you accept that criticism or not?
Yeah, that depends on what you mean with we. I'm sure that that it is correct to say that in general in the health systems in the world and in Europe, there's not sufficient focus on prevention, and only a tiny part of the overall budget is spent on prevention. And we have been saying that since years, and not much is moving. But let's say in our initiatives, I think there's a strong focus on prevention. And we are collecting best practices on prevention. We try to spread them. There will be a new joint action, which will cover both non-communicable diseases in general, but also cancer, which will be funded, I think, with 75 million on health determinants. That's actually the first action under this plan. And that's basically entirely focused on prevention, if you so wish. So I do think that at European level, at least, we are totally aware that prevention is key and there's enough focus on prevention, even though that can't indeed solve all the problem. But again, I come back to what I said in the beginning. The real challenge, the one real challenge is to find ways to motivate member states to actually invest more in prevention. And that is a political problem. Yeah, because without any doubt, you have to take care of the patients who are already ill. Yeah, so you cannot shrink that part of the budget and increase the prevention part of the budget. That is absolutely clear.
You need more resource in order to do it, not moving resources.
Indeed. Yeah. Indeed. And then the second thing is, of course, what we also have been saying since a while is that the health systems themselves should focus more on prevention. They are usually focusing just on treating patients with diseases, and they are not as active on prevention as they could be from our perspective. And that is also something we try to promote in member states. But again, it's a question there, on the one hand, of political will. And secondly, also, it means that a system which works in a certain way since many decades will have to change the way it works. And that's always difficult to implement. And as I said, we are trying to collect best practice on that. I mean, I remember in that respect, for example, in our efforts to spread best practices, we have one project on a best practice, which actually means, I think it comes from Sweden actually, which means that doctors can also prescribe not only medicinal products, but physical activity.
Yes, yes, yes.
And that is something which we now spread over more European countries. And we have a group of countries that is interested. And this is what we try doing in practical terms to overcome the barriers which are there, without any doubt.
Thank you. And Neil, I know you want to react again. I just want to read out a question from Marius Gianta, who says, how do you see the role of personalized prevention in the CVDs area in the context of EU initiatives such as the CSA on personalized prevention? Don't know whether anyone can pick up on that, but Neil, you wanted to come back in.
Yeah, just a question or just a comment in relation to the secondary prevention issue. So, and it actually has huge financial implications. We have by and large, we have the technologies and the therapies to deal with diagnosed cardiovascular conditions. But we know from constant Eurospire surveys of secondary prevention that while by and large most patients are medicated on the right medicines, for example, there's an unacceptable level of waste, if you will, by the fact that so many patients are not reaching target. And this is not down just to the patients. Several studies can confirm that this is a multifactorial concern. But if we were, for example, optimizing therapies, and that will require things like potentially incentivization, which has been raised in the report, we could do a far better job. There is an unnecessary and massive waste of resource in not ensuring optimal use of therapies.
Thank you. I want to come back on that issue of incentivization as we look to the future. But Paul, just on this issue, because it's very much and echoed by members of our audience, about it's a political choice. Where you put the money. And Stefan has talked twice now about motivating member states to invest, particularly in prevention, because as he says, it can't be at the expense of existing patients, but also motivating them, is the phrase he used earlier, to do things in a different way. I mean, how important for you is that political signal that could be sent? And we're going to come in a moment to what might be in an action plan to deal with this, but the political signal that the existence of such a plan would send in convincing member states of the importance of this. What do you think? You're muted at the moment, Paul, sorry. Hang on. You're still muted. There we go.
As you know, the European Economic and Social Committee is an advisory body. And now we started an own initiative report on emergency preparedness, because in emergency preparedness, the security of supply plays a key role. So if we speak about prevention and preparedness for emergencies, of course, there is also the question of response. And if the response was okay, it's the recovery, and then there's the mitigation in this emergency management, and at least we will have a rehabilitation. So the whole value chain is important for the political level. And as I always say, the individualized treatment is key for this. And of course, also looking to the return on investment of all these activities which we do, because the quality of life is a high investment. And I think that's important to see how we spend our money, the taxpayers' money, in the best way to create a sound, healthy environment where advisory plays a key role, and how can we integrate the new technologies, what's possible to do via mobile phone. It's so much equipment now around which supports these health issues. I myself wear some things with me where I can check my health, my blood pressure and whatever. And of course you get then the apps in the mobile phone, and a lot of apps are popping up, which are really good to use.
Indeed.
The knowledge and the education for our people to make it possible to use these new technologies. The EIT Health plays a key role because communicating knowledge in the areas of wide space of knowledge, that's key. And so the political level, of course, at least is a communication level and a management level. And I think we should do our utmost to give good signals into this direction.
Thank you. I just wanted to, Peter's waving his mobile phone at the screen. Peter, what are you trying to show us? We can't really see what it is.
You know, I just started at for my own blood pressure. I have had a smaller heart attack for a few years ago, and no doctor want to care about me. So I saw it on the net and found a blood pressure doctor, and I'm so, I should use some words, but so tremendous good about asking me the right questions and sending me a free blood pressure meter. And I'm so satisfied. I'm looking forward to see my digital doctors in 2 weeks. I'm so glad about that.
Something maybe be awareness, raising awareness of that these things exist. Birgit, you wanted to come on in this point, and then I wanted to just ask Peter a question, another question relating to data and digital capacities, and then I'd like to focus really on what does all this mean for the Healthier Together initiative, for actually, you've all talked about the need for national plans, for a European plan. What do we need to see in them? But just if you would, what Birgit, you wanted to come back in.
Yeah, just quickly on the political will. Maybe that already jumps forward with the idea. But let's say it is a decisive moment we have now. There's a political will. The alliance came together. The European Commission has put forward a health program 10 times as big as ever before. So we have a unique opportunity to stimulate at European level, at national level. We see that in member states, they're coming out. There is a Scottish CVD plan. There is a German initiative on a strategy for CVD. In Spain, just brand new, I haven't seen it yet in detail. There's another plan. So I think we have to use and seize the opportunity which were created by COVID, but made us aware how important is CVD, how important is health, and have a plan there in place. And I think this is why each came together with all our partners and pushing forward. So we're looking very much forward.
We need a plan. In a moment, I'm going to ask you all what you think needs to be in it. But Peter, just on this question before we do that of building the digital and data capacities, you talked earlier about collecting data immediately. You said we can do this much more straightforwardly, much more simply. You also talked about harmonization and standardization. What can we do? Do you think we're on the right track to get there in terms of addressing those issues? And based on your experience, could you just say 2 words about how the data that you've collected is used and how much difference you think it has made to approaches to this issue and to really targeting the interventions, continuing the treatment, that continuum of treatment and care that is needed?
When we started collecting data in Sweden, it was hidden. We thought it was, no one should see it. Of course, not the public and not the government. We wanted to just keep it in our profession. And then a very famous TV digging journalist asked about our information, and no, we can't give it away to the public. And then it all started to, now we give away everything we have. We are paid from the government, and all our data are public. Who wants can get the data. And then the main thing we are doing is transparency. We publicly, we make the data publicly, and then people look at the data and look at that hospital, that primary care, they are doing like that. Why have they those results? And then year after year, you're thriving to getting better.
And does that link back to your very first point when you talked about the trust and confidence of the public?
Yes.
Is that the key?
Yes, that's the key. Exactly, that's the key. Exactly. Okay. The Swedish people have a tradition of trusting the church and government, and they let us collect our data. And you know the personal numbers in Sweden. We let the authorities collect the data. We trust them.
I don't know whether either Birgit or Neil wants to comment briefly on that from a patient perspective.
Yeah, I could quickly mention that the trust is decisive. A certain aspect of data protection we need. We can't completely leave it without, but I think it is to the advantage of the patient to have consistent data wherever he or she goes into the healthcare pathway. So when he is as a specialist, he knows what has been prescribed by the GP. So we need to have this consistency to protect the patient and have quality care. Patient safety. So
Neil,
it's
did you want to,
important.
You want to add two words on that?
Yeah, no, I absolutely agree with what Birgit has said there.
Thank you. Okay, I want to now really focus on what does all this mean. We are expecting, and perhaps Stefan, you can bring us up to speed on the timeline for the EU roadmap for non-communicable diseases. I don't know whether you can give us a sneak preview of what we're going to see in it, but where are we in that process? And then I'd like to get a sense from each of you of what you want to see in it, and particularly what you want to see. You've talked about the importance of national plans and EU plans, particularly because we're talking in an EU context today, what the EU can do to really drive this forward. But Stefan, where are we in the process? When are we going to see the roadmap?
So if we are lucky, this will still happen in June, yeah, if all goes well. I can't commit to anything there. But what I can say is that for all those who are actually interested in what exactly should this initiative cover, the next meeting is on the 3rd of June. There we have a meeting under the health policy platform to discuss the initiative, and particularly the strand on health determinants, because as I said, there will be actually a joint action on health determinants. And that joint action will, to a large extent, determine what we are going to fund under EU for Health in the member states. Yeah, of course, there's also one on cardiovascular diseases and diabetes, yeah, not to be forgotten. And also there we will discuss with member states, also after discussion with stakeholders, what we are going to propose. But as I said, it's not that it's clear that political signals are important. There's absolutely no doubt. But it doesn't work like member states are not motivated to do something, and then the Commission says, yes, but this is now what we should be doing, and then they will just do it. We need to ensure that there is a congruence of what member states are motivated to do by themselves and how we can help them at European level. Yeah,
thank you. Okay, so there is that opportunity on June the 3rd, but I'm going to give you that opportunity to say it now. Paul, what do you want to see in that roadmap specifically? What are you hoping for? You're muted at the moment. Thank you.
Yes, I think what I will do, because, you know, action should be followed to our debate, and what I can do from the Economic and Social Committee, I will ask the European Parliament's research service to come up with a mapping of new teaching and learning technologies, because it's very important to see how we can get all this knowledge to the citizens and to the patients. And the second question is, do we have specialized search machines to give to a broad public, but also to the specialists, a better insight? As an example, we have Symptoma. It's a new software where you go on and where with different kinds of checklists, you can get better knowledge about your status. And I think it's not a competition. I think it's a support for the healthcare system if we have informed patients. If they know, if they can express much better what they feel and what the issues is, if they write down themselves, if they use the software to see how the blood pressure changes and whatever. So also for the healthcare system, it's very important to have educated consumers. And therefore, I want to initiate an initiative on this study, and maybe the Commission can help us to see what would be the best pattern to get good solutions.
Thank you very much. And a member of our audience talking about, going back to our discussion about early detection, really wants to see in that initiative more to enable early detection programs with a European initiative for a cardiovascular health check, for example. Just a comment from our audience. But Neil, to what you want to see in that package and where you see the role, where can the EU really make a difference alongside those national plans that you're pleading for?
I think for me, there are three things. Firstly, I think at a citizen level, we need to reframe the public discourse on heart disease. We need to educate the public. We need to talk about investing in cardiovascular health. We need to educate that, you know, there is ASCVD and non-ASCVD. There's metabolic and there's inherited. And people need to understand the difference and the role they can play in promoting their own cardiovascular health. Secondly, I think we do need to have universal screening at birth, for example, for childhood genetic conditions, and then life stage screening, what somebody just mentioned, regular cardio checks. And that might be in their 20s, 40s, or 60s based on risk assessment for various cardiovascular conditions. And of course, central to that is going to be the data we talked about and the way that that data is used and connected. And thirdly, we need to have some incentive or value-based, outcome-driven strategy to implement evidence-based, guideline-directed approaches to detection, diagnosis, treatment, rehabilitation, and ongoing maintenance of healthy cardiovascular life.
And just briefly, what sort of incentives do you think would be most effective?
Well, I think we need to think outside the box here. You know, for example, at the individual level, why would it be so crazy not to incentivize the individual for promoting or for maintaining cardiovascular health? That could be, for example, things like reduced life insurance policies. It could be pension top-ups. It could be tax credits. I think we need to think outside the box as to how we motivate, because ultimately what we're talking about here is behavior change at the level of the individual. And we know that there are many ways, and behavior change is complex, but there are many ways in which you can use the carrot, so to speak, to guide behavior.
Thank you. Birgit, same question to you. What do you hope to see, and how do you see specifically where the EU can really help alongside national action?
So the European Alliance for Cardiovascular Health will launch its report on Monday. So I'm not allowed, it's embargoed, but I could give you a few elements.
Sneak preview.
Sneak preview, exactly, as you say. So exactly, the cardiovascular health plan we need. So it's a dedicated, structured finance plan, systematic, which, like cancer plan, has elements of future policy, not just this year for June, until 2027 at least, to build it, a solid block of planning and decision making. Then we need underpinned by research. That doesn't stop that we need cardiovascular research to be more innovative, to foster, bring on new scientific evidence and new elements that help the patients. Then early detection, we discussed, we need to use the early detection in order to enable early intervention, treatment, and care. Then the big topic we just discussed a lot, leverage digital technology and health data. I think we have a big homework there to do, but it will help, it will bring results, and it will bring outcomes. And we're going to the registries from Sweden. It will bring its results, no doubt about it. And last but not least, Neil referred to it. We need also the awareness not only at individual level, but also at political level. We need to grasp the understanding that we can't continue as we used to do. It's like Albert Einstein said, you can't expect changes if you continue doing the same thing all over again. So we need a new plan, and that's we'll hear more about it on Monday.
Peter.
For the first, of course, as I'm saying it, work close to your data and react on your own results in transparency with other centers. Implement existing knowledge, of course. Continue to research to have new knowledge. And I haven't mentioned the cheap Swedish way to have new knowledge, registry-based randomized clinical trials. Second, not just ask what the doctors and government can do, what can I do myself, personal responsibility, and then of course, the importance of physical activity as the main pillar for maintaining health. The third, what can we do as healthcare providers, and that we haven't talked today, recruiting staff and to be attractive employers. For the fourth, everything can't be measured. My mother said the last month before she died, I don't care about doctors and nurses. The most important thing is kind and nice hands from the assistant nurse.
Thank you very much. Stefan, a reaction to all of this, and perhaps also to that comment question from the audience, in particular about the idea of a European initiative for a cardiovascular health check. Just a reaction to what you've heard, if you would.
Well, first of all, what we are going to do is to now properly spell out what will be done as part of the Healthier Together initiative. And so we will have on the 3rd of June this discussion with stakeholders via the health policy platform, and then the 2 joint actions under the 2022 work plan, the one on cardiovascular and on diabetes, and the other one on health determinants. That is also very important to spell out what exactly will be done, because they are funded with very high budgets compared to what we had to before in recent years. And it is very important for us to get this right, to spell out meaningful interventions in the member states which can be implemented with these joint actions, which will have an impact. Because if you look at European level, we also have to demonstrate that we can actually do something which makes a difference for citizens with this increased budget of EU for health. Because what we have in mind is also to ensure that then when this financial perspective is over in 2027, that then from 2028 onwards, we will still be able to make meaningful health policy at European level. It's also in that perspective very important that we make a difference. Yeah. So therefore, what I want to say here is that we will probably not be able to do everything we would like to do with them, even with that increased budget. But I think we have the chance to make a big difference to citizens anyway, and to demonstrate the added value of doing this at European level.
Thank you. And I know you probably wouldn't want to answer my final question to you all, and it's a very brief one, and I want to come to Paul at the end for a final thought as our host of this event. But for you, Stefan, is there, we don't have to go into the detail of the plan, but of all the issues we've talked about, for you, is there a personal thing where you say, that really, above all else, we need to focus on that, a key next step in all of this? Same question to you all in just a sentence or so each, if you would. Stefan, do you have a personal priority here?
Yes, I would say quite clearly, in a way, I come back to what I already said. We have now a much bigger EU for health budget, and nobody is used to making use of such a budget in the area of prevention with member states. So what I think is really most important, that we get this process right of turning, let's say, the results of our discussions with all stakeholders and the member states into something which is really implementable with the instruments that we have. So sorry that this is not particularly visionary, but I think for me personally, that's the most important thing, to turn the theoretical opportunity into something practically which makes a difference together with stakeholders and member states.
Absolutely. Thank you very much. Peter, your key priority, key next step.
I want the healthcare in Europe to be like IKEA healthcare, cost-effective and innovative, and healthcare for all. Thank
you very much. Birgit.
I think keep people healthy and manage their risk early is a good slogan, and health as well. So I'm happy to see that there's a budget for it, and that we can talk structuredly in a joint manner with all stakeholders together, with policymakers, European and national level, in order to make use of this money and implement a plan that will change, game changer for CVD health.
Thank you very much. Neil.
Yeah, I think as Stefan and Birgit has said, we're on the cusp of a unique opportunity from a budgetary point of view to really make a difference. But ultimately for me, the key thing here is this has got to trickle down all the way down to the average citizen or patient. And at the end of the day, we've got to be able to say that what has been implemented has made a difference to their pathway and that they get the best possible care for the best possible outcome.
And Paul, a final thought from you, if you would. What for you is the most important issue we need to address, or the key next step that we need to take to really, we started by talking about how important this issue, how urgent it is. Do you have a key priority? And I see Ömer is back with us on the screen. I don't know whether he wants to also highlight his key priority, but Paul, your thought.
Yes, what I learned at this meeting is that genetic diagnostics could play a much more important role. I was not very long time ago at a research institute called Novi Kenya, where a genetic diagnostic was charged for 2,000 euro. So that's of course not something which we can finance for everybody, but I think it's just a first step because they are using artificial intelligence to look what in the genetic diseases, what is the cure system within it. So it's a own global science issue, and therefore I'm happy that we got this into this debate as well. And of course, what is my main message? I think to quote it like the European Economic and Social Committee would say, we would do everything to keep taxpayers healthy because then we can afford the investment into our health and into our health system. And that's one of the key messages, that of course we need the one who earn and the other one who spend. And this should be a nice relationship where both sides have good benefit.
Thank you. And Ömer, just as you've reappeared on my screen, you highlighted the recommendations in those 3 key strategic areas. Would you pick one or a key next step, briefly, if you would?
I very briefly, I think this session has demonstrated that there is actually convergence between all the stakeholders, not actually competing interests. I think that's very crucial. If you allow me, Jackie, I would like to reiterate and reverbalize my commitment on my behalf, and I know my colleagues share the same sentiment. This group is very keen to utilize the currently formed partnership. And if anyone in the audience, given the importance of converging thoughts, need to move from strategy to action, if anyone in the audience is listening us out and has thought any of these ideas they could contribute to, please reach out. We are not going to leave this initiative at this stage. We're going to move this forward with the colleagues, and we need the ideas that we can put into practice ASAP with the contribution of all of these distinguished experts who've shared their opinions. So thank you very much.
Key partnership with everyone, all the players in the ecosystem that's needed to deliver on all the issues you've raised. We are out of time. I wish we had twice as long, so much to discuss. But thank you very much to all our panel. Thank you, Stefan. Thank you, Peter. Thank you, Birgit, Neil. Paul, thank you for hosting us and joining our conversation. Ömer for presenting the study. And thank you to all of you for joining us today for this fascinating discussion. I took many of your comments and questions, couldn't squeeze them all in, but very grateful. It only remains for me to wish you a pleasant rest of the day, a good weekend, and continue to stay safe. Thank you, and goodbye, everybody. Thank you, Paul, very much for hosting us today. It's been wonderful to have this discussion. Thank you.
Goodbye.
Bye-bye.
Bye-bye.